Good afternoon, everyone. Can you hear me okay? So my name is Zuzanna Angehrn. I represent a company called Untitled Chapter that was able to participate in roadmap thanks to Novartis, a pharmaceutical company. We are a pharmaceutical company consultancy. And I'm here to present to you the results of a collaborative work of a group of researchers within Roadmap on the ethical and social issues related to using predictive modeling tools for prevention of Alzheimer's disease at preclinical stages. So I understand that the title is a bit hermetic, so let us break it down into smaller pieces first. And also, if there are questions related to the content, I mean, to the understanding of the content, I'm happy to take them as we go. So maybe to introduce the concept of secondary prevention of AD, I realized that this has been discussed on several sessions during the conference, so the prevention of AD, but I hope we'll be able to tackle it here from a slightly different perspective. But let's start with this definition. So secondary prevention is a prevention that targets people who have risk factors or biomarkers typical for Alzheimer's disease, but do not have symptoms yet. So when we look at this chart that presents the Alzheimer's disease progression, that would be the place where people are targeted with a preventive measure. So a time when they do have some risk factors, they have some changes in their brains, but they don't have symptoms typical for Alzheimer's disease yet. And maybe a word about the typical prerequisites for pursuing such a preventive approach in general within the public health framework, not specifically to AD first. So generally, we want to prevent a disease when we know that there is a large unmet public health need. Second of all, we have a relatively good understanding of a natural course of a disease. We know how this disease progresses well enough to be able to make this link between what we do at the preclinical stage and further on. And then disease-modifying intervention exists so that we could actually offer something to people who are, so that we can offer something to people who are potential future patients. And this disease-modifying treatment is accessible and affordable. Not the final, but the further prerequisite is that potential intervention is offered to either everyone who needs that or who can potentially benefit from that, or there is some way to select out of pool of people who could potentially use this treatment. There is a way to screen and select those who should actually take it. And then final prerequisite is that this prevention is more cost-effective than treatment. So let's quickly have a look at how the situation is in Alzheimer's disease at the moment, according to the way we see that. So first of all, yes, there is large unmet public health need in Alzheimer's disease, so there is a rationale to pursue this topic at all. In terms of understanding of a natural course of disease, we do know some on that, but it's still not entirely clear how the preclinical changes translate into final outcomes or symptomatic changes in Alzheimer's disease. That's why I would say yes, no, maybe. We know something. We haven't uncovered everything yet. Disease-modifying intervention does not exist currently in Alzheimer's disease. Therefore, we cannot say if it will be accessible or affordable to the patient. I'll speak a little bit later about that, but in terms of specific screening techniques, we don't currently have a screening for preclinical Alzheimer's disease, but the predictive algorithms that can potentially be used to identify people who at risk of developing Alzheimer's disease in the future are I would say our work in progress are becoming more and more powerful. So we are on the way to find such a way to identify people who develop Alzheimer's disease early. And finally, we don't know yet whether prevention will be more cost-effective than treatment, but given the scale of the problem in Alzheimer's disease, we can suppose that this will likely be the case. So maybe now to explain why do we talk about predictive modeling in this context. So just to recap of why we need to make it so much more complicated by adding a predictive modeling component to a topic of ethical issues in AD prevention in general. So before I jump into that, let me explain to you what I understand as predictive modeling. And predictive modeling would be a prediction of future outcomes based on historical data. So we want to predict what will happen in the future based on the data we have gathered in the past on a similar subject from similar people in a similar context. So how can predictive modeling help in AD prevention? So first thing would be it could help us understand the disease-modifying properties of a new treatment, because we know that in a clinical trial setting, we are able, trials last, let's say, up to 5 years, so we can observe potentially some changes or some positive changes in the lives of people with Alzheimer's disease, but we will not be able to observe all of them because of the long progression of Alzheimer's disease. I'll touch upon, or maybe I'll jump. Yes, I'll jump to this now. So this is just to show what I mean by that. I mean that in the clinical trial setting, we can observe potential changes in the lives of people who are at risk of Alzheimer's disease on cognition and maybe on function, but we don't know whether changes observed on cognitive scores will necessarily translate to what we know is the most meaningful to patient, and that would be quality of life, that would be whether patients can stay at home, whether they can pursue their hobbies. This is not measurable in a clinical trial. So going back to other reasons to use predictive modeling in Alzheimer's disease setting. As already mentioned before, predictive modeling can help us identify patients that are at risk of developing Alzheimer's disease from a general population, from all of us. It can help us pick up the people who are actually most likely to progress. And also, predictive modeling can help us address the challenges related to the cost-effectiveness questions and economic evaluation of preventive strategies. So now, what we did in Roadmap, we pursued this question: what are the ethical issues raised in this context? And what are the social implications of this preventive approach? So we did a systematic literature review. This means we searched databases of scientific articles, but we also looked into gray literature, into reports and communication produced by organizations such as WHO, OECD, and Alzheimer Europe, and many others, just to make sure we have covered a broad spectrum of evidence. And we looked for documents, papers, reports that were discussing intervention at asymptomatic or other pre-symptomatic AD. So we looked for studies discussing AD in the context of people who do not have a mild cognitive impairment diagnosis yet. And we were looking at studies discussing either predictive modeling method, so use of statistical algorithms, or data that would typically feed into this method. And we wanted studies that provide some ethical discussion or commentary. And what we did, we looked at this paper, extracted data, extracted argument, extracted discussion that was contained in this document in order to capture novel ethical concerns and social implications within the certain themes that emerged from the literature. And we also wanted to investigate their interconnections. So this is to provide an overview of how many papers we reviewed, how many we found, how many we reviewed. So in general, we found 180 papers, documents, using this approach. And we removed, so we looked at whether they qualify or not to our study, after which we were left with only 48 that actually met the criteria that I just showed before on the slide before. And most of them were journal articles from different fields, so medicine, gerontology, psychiatry, neurology, neurobiology, and neuroscience, just 3 in ethics and social science, and 12 interdisciplinary papers. We also looked at 7 conference abstracts, 3 books or books chapters, and 6 reports. So here it's a broad overview of the results that we found, that we structure along what we called patient journey, although we understand this is a very, very broad way to present that, or to a very coarse way to describe that. So first of all, we looked into the topic of model-based screening for future potential AD. And what we found is that there are different propositions about who should potentially be screened for preclinical AD. So one proposition is all people above certain age, or those who would want to be screened, or those with risk factors already existing, or those who can handle diagnosis. So what we found a concept in the literature that we call screening before screening. So some sort of procedure or evaluation that would allow to kind of measure upfront whether, you know, how a patient would, or how a person diagnosed with preclinical AD could handle such a diagnosis. Then a very prevalent part of the literature deals with the disclosure of the predicted risk. So this is typically in a research setting. So when there's a discussion of patients who are recruited to, let's say, AD trials, and there's discussion, should we actually tell these people recruited to the clinical trial what the results of the screening is. And one of the common ethical concerns is that, in fact, at the moment, in the absence of disease-modifying treatment, it just extends time that a person spends as a patient without providing additional benefit. And important consideration is that this diagnosis might in fact be irrelevant, because people will live for many years without feeling consequences of Alzheimer's disease. They might in fact deal with many severe immediate health issues that are not AD. So why would they have to handle this burden of preclinical diagnosis? Of course, there is a mention of how preclinical diagnosis can lead to depression, stigma, and discrimination. But some literature says, but patients can also benefit from that and make provisions for the future, or they can use the time that they have in a way that they find the most relevant or worthwhile for them. I guess I have to speed up. So another group of ethical concern is the question of access to treatment based on the prediction of whether a patient will develop AD or not. And then the themes that are present here is, of course, equity and access to any future treatment. So there's a question of, well, you know, even if we have disease-modifying treatment, will everyone be able to benefit from that? Or will everyone be able to afford that? And this is considered not only on a, let's say, country level, but also in a transnational level. There will be countries that will be more, where people will be more fortunate in that regards than the others. And then another topic is discrimination, potential discrimination of people with preclinical AD diagnosis, and also distributive justice. There is a point that too much focus on preclinical AD might in fact lead to diverting some resources from dementia itself, from symptomatic dementia. The next group of ethical concerns is the assessment of the long-term benefits of treatment. So there is a question of making good versus not harm the patient, but also unclear rationale for extended treatment of people who do not have symptoms for a long period of time. Moving very quickly, let's jump to the final group of ethical concerns, is the social implication of doing this versus not doing this. So of course there are ethical issues and concern around predictive approach, but we need to ask ourselves, what will happen if we don't do that? What are the consequences of letting go opportunity to prevent AD early? So I'll just set this slide, I will use this slide just to illustrate how we found complex these issues are. I mean, they are not linear by no chance. They are strongly interconnected, and they strongly feed one to each other. And the answers that we give ourselves at each consecutive stage will implicate how we handle or how we deal with the subsequent group of ethical concerns. And in the interest of time, I think I will stop here. I just would like to say thank you for your attention. I'll be very happy to hear from you and learn a little bit about how you feel about this subject. And I would also like to acknowledge the whole team that was very diverse that contributed to this study, among which we had individuals from different organizations and with very different backgrounds. So thank you for that.